The first question was, is this a risk factor? Which one of this is not a risk factor for prostate cancer? The correct answer was smoking. Smoking is not a risk factor for prostate cancer. Increasing age, African ethnicity, obesity, family history, and a BRCA2 gene carrier are risk factors. The next question was, you have a 62-year-old gentleman who's got voiding lower urinary tract symptoms. He's got a PSA of 2.3. His DRE was suggestive of benign feeling prostate. His histology has come back as a Gleason 3 plus 3 is equal to 6 prostate cancer in less than 5% of the prostate chippings. What is the correct TNM staging? So the answer here is T1A because you've got less than 5%. The reason why it's NX and MX is we haven't staged these patients, so we don't know the nodal or the metastatic stages. So this is something to bear in mind when you give your exams. N0 and M0 is not the correct answer. The next question is a 73-year-old gentleman who's been investigated for a raised PSA with a prostate biopsy. He had a Gleason 4 plus 3 prostate cancer. And how does this translate into ISUP grading? The answer is grade group 3. So the answer is C. The next question is something Dr. Helen Turner touched on today. We presented to you various reports of prostate cancer. So one of the prostate cancer reports showed that the person had a cribriform pattern and also reported it to be a Gleason 6 prostate cancer. This is not compatible. So the correct answer is A. The next question is number 5. Which one of the following statements about PSA testing is not correct? So the answer to this is B. We mustn't routinely offer patients PSA without appropriately counseling them, particularly if they don't belong to risk factors. So it's important for you to counsel them about the pros and cons and the harms PSA testing does. The next one is, which one of the following statements about multi-parametric MRIs is false? And Dr. Patel covered this very nicely today. The diagnostic accuracy of multi-parametric MRIs is dependent on the quality of your images and the acquisition techniques that your individual machines have. And it also depends on the expertise of the person who's reporting your MRI scan. So we can't emphasize enough the importance of auditing your own outcomes. So the correct answer is C. The next statement is the following statement about prostate biopsies is false. So if, and the correct answer is B. So if a prostate biopsy does come back as negative, which does not show a malignancy, this does not completely rule out cancer. These patients can have false negatives. So this is something that needs to be borne in mind. And the final question was, the following statement about localized prostate cancer is correct. So active surveillance, Dr. Hanchanali spoke about this in some detail, is a valid option. And you can see that we say that both surgery and radiotherapy are equally oncologically efficacious options and have to be offered as equal partners, particularly in intermediate risk prostate cancer. So we will now start the MDT. Case 1 is a fit gentleman who's got culture-proven urinary tract infections. He's got some voiding lower urinary tract symptoms. He's got a benign feeling prostate, and he's got a PSA of above 25. He's had a uroflowmetry done, and this shows an obstructive flow. Rajan, you have 3 options here. You can offer this patient antibiotics, you can do a prostate biopsy directly, or you could perform a multi-parametric MRI. What would your treatment of choice or investigation or approach of choice be here, Rajan?
So this gentleman has had a proven urinary tract infection, so his PSA could be elevated because of this infection. So I would initially treat him with antibiotics and then repeat his PSA after an interval of about 8 weeks just to see if it has come down after treatment of the UTI. There could be other reasons for his elevated PSA other than prostate cancer, and infection could account for that in him.
Okay, so we've treated him with antibiotics for a good period, and his subsequent investigations, culture and sensitive, have come back negative for infection, and his PSA, if anything, has gone up to 29.
Okay, I think in that case we'll proceed to a multi-parametric MRI if there are no contraindications.
So I would agree with that. So in terms of the diagnostic process, our preference is to organize a multi-parametric MRI first, because this will reduce the detection of clinically insignificant disease, but increase the detection of clinically significant disease. So that's important to be borne in mind. So we do an MRI scan. Amit, this is the MRI scan that we have. Would you be kind enough to describe this to our viewers?
Yep, so we have a T2 sequence in the top left, followed by a high B value sequence top right, which is showing a bright area within the anterior transition zone. So going back to what we spoke about earlier, the dominant sequence for transition zone is going to be the T2. So really, we don't need the diffusion sequences here. We can make the diagnosis based on one single image, which is that T2 image. And as you can see, there's a lenticular area of low T2 signal, which is in the anterior right transition zone. As I mentioned before, most tumors in the TZ are anterior, and this is crossing the midline. So this is above 1.5 centimeters in size. So it would be equivalent to a PIRADS 5. And we can see that the capsular margin is preserved, and it doesn't appear to be extending beyond the capsule. However, with that extent of capsular abutment, you always need to be concerned about the possibility of at least microscopic T3A disease.
Excellent, Dr. Patel. I think we've shown great inter-observer agreement here. So both our radiologist and Dr. Patel have come out with pretty much the same report. So this is a PIRADS 5 lesion, and because of the broad contact, we are suspicious of a T3A disease. Now, we've got 4 options here. We monitor this lesion, we do a targeted only biopsy, we do a systematic and targeted biopsy, or we provide active treatment purely based on an MRI because the suspicion of cancer is high. Rajan, what would your treatment or diagnostic strategy be here?
Well, this particular case has got a high grade PIRADS 5 lesion. It's an anterior lesion. I think I'd offer him a biopsy. I think the biopsy would best be done through a transperineal route, which would allow us access to the anterior part of the prostate. As alluded to before, we personally would perform a targeted and systematic biopsy, and this is currently the approach backed by the EU guidelines for a biopsy-naive patient to perform both a target and a systematic biopsy. I'd perform a cognitive fusion biopsy.
So excellent, and that's what we did. We proceeded with the transperineal biopsy, and this came back as a Gleason 3 + 4 is equal to 7 prostate cancer. It was a grade group 2 prostate cancer because it's 3 + 4. Remember again, if it's 4 + 3, it becomes grade group 3. And there was some perineural invasion. So we performed a bone scan, which was negative for metastatic disease. We didn't do a PSMA PET scan, but for discussion's sake, if we did one, it was negative for metastatic disease. So based on the parameters that we've used, we've got the risk classification. This would be a high-risk prostate cancer. Do we have Dr. Hanchanale or Dr. Gautam in the panel?
I'm right here, Bhavan. Hi.
Okay.
Vish is also here.
Vish is here, and so is Brian Chaplin. So we've got 3 surgical consultants, and we've got an oncologist. So we have the options between radical prostatectomy versus hormones and radical radiotherapy. If this patient didn't have any low urinary tract symptoms, he was otherwise an index patient, is there a preferred choice, or should we be offering both treatment options as equal options to the patients? Brian, what do you think?
Well, I think
we'll get Brian to unmute himself.
So I think, yes, if he didn't have low urinary tract symptoms, he could equally consider radical surgery or radical radiotherapy, which would probably be combined with hormones. If he was to have radical surgery and was to have locally advanced disease, then this would still be a good treatment option, or could be a good treatment option, because it could be the first step in multimodality treatment.
Fantastic. Gagan, what would you say?
Bhavan, I didn't catch the first slide. What is the age and comorbidities?
So he's a very fit patient, Gagan. He's young. He's around in his 50s, and he's staging or his risk stratification would be high risk.
So I would be, obviously biased, but I would definitely consider him for surgery as the better option here. And for pretty much the same reasons that Dr. Brian is saying, actually, that being young and having an excellent life expectancy in the long term, we need to keep all our weapons intact as far as management of his prostate cancer is concerned. And though there's no clear, level 1 evidence for an improvement in survival with a multimodality treatment, I do believe that in the long term, doing surgery first and reserving radiation therapy as a secondary option is likely to translate in a better overall management for the patient. So I would probably say that for a young, fit patient who's able to take surgery, who has lesser chances of having incontinence after surgery, probably radical prostatectomy with an extended node dissection would be my treatment of choice.
Fantastic. Rob, what would you like to say to that?
I think, yeah, in this case, if this chap's mid-50s with significant LUTs, then I think even from an oncological basis, I think surgery would probably be the slightly favoured option. I think he does have the choice, though, of hormones and radiotherapy, and I think it's a valid option for him. And if this chap was coming into my clinic, then, he'd certainly be getting probably up to 2 years of androgen deprivation therapy. And I'd talk to him about radiotherapy to his prostate gland, and I'd probably also discuss with him elective treatment to his pelvic lymph nodes, because he's probably got a significant risk of nodal disease as well.
Rob, if I could just ask one more question. In terms of local prostate treatment, would you give him some brachy boost in this kind of situation if he didn't have low urinary tract symptoms and if he didn't have trouble with culture-prone urinary tract infections?
I think so. I mean, I think as we didn't really get into this in my talk, but I think we did briefly mention, I think more dose is better. And I think particularly in young patients, I do fear sometimes that with higher risk disease that, the late failures, and we do know that higher dose to the gland does certainly reduce the risk of a local relapse further down the line. So I think in an ideal world, this chap would be suitable, particularly given his age, for some form of boost strategy, either with a HDR brachytherapy or potentially LDR brachytherapy.
Fantastic. In this particular case, we chose radical prostatectomy. I will ask Vish. Vish, would you offer this person a pelvic lymph node dissection? Why would you offer him a pelvic lymph node dissection? And what is the template for your pelvic lymph node dissection?
Yeah, he is a high-risk patient with a very young and moderate to severe lower urinary tract symptoms. Surely my preference would be towards surgery. And to that, I would add up with, as Gagan mentioned, it's a standard lymph node dissection for the prostate cancer, which will involve the obturator external iliac and the internal iliac section. That would be my preference.
Okay, just to summarize the discussion, there is a little bit of controversy on the role of extended pelvic lymph node dissection. All of us believe that it is probably going to benefit patients, but there's no evidence to show that it really improves survival. And we use a number of nomograms. As Gagan has said, you may have to cater it slightly to your regional and behavior and demographics locally, but the accepted standardized nomogram is a Brigandi nomogram, and if you have a higher than 5% chance of lymph node invasion, we often offer it, and the accepted template is still the bifurcation, iliac bifurcation at the crossing of the ureters. The one other point I'd like to make is that lymph node dissections are either all or none. You either perform an extended lymph node dissection or don't perform anything at all. There's no role for obturator sampling or obturator lymphadenectomy. Now, I'd like to get, so this is actually a real case with some minor variations, which me and Rob have been involved with. This patient, his histology came back as grade group 3. So this is a good example of upgrading. The staging was T3A, which is exactly what the MRI had suspected. We did a very extended lymph node on him. We had 39 lymph nodes that we extracted, all of which came back as negative. His immediate PSA was negative, or was undetectable rather. Rob, what is your views on offering adjuvant radiotherapy versus delayed or salvage radiotherapy?
Yeah, so as probably most people will be aware, the Radicals trial reported in the last year or so, and again that suggested that patients don't need to launch straight into adjuvant radiotherapy, that actually taking early PSA readings and salvaging at an early point. So I guess a PSA of 0.2 would be a fairly standard way to think about that, but I would certainly consider some patients selectively at a lower level if they clearly had a positive margin or other high-risk features. So yeah, our standard practice at the moment is initially PSA surveillance with a plan for early salvage radiotherapy at the point of biochemical relapse.
Just to let all of viewers know, this man has been 1.5 years and he's now had a PSA relapse, and we are considering him for radiotherapies. PSA is, I think from memory, 0.32. So, but no harm done. So the summary is that, our diagnostic strategy is a pre-biopsy MRI. This will help you detect clinically significant disease, but most importantly, you do not identify clinically insignificant disease, and this really must be the effort. We suggest targeted and systematic transperineal biopsies. Some units which are units of excellence and have excellent diagnostic accuracy performances may want to consider only targeted biopsies, but we would suggest for every unit that's starting off with the MRIs, a systematic and a targeted biopsy. And a TP biopsy would be our favorite option because it reduces the infection risk. We're very appreciative that not all units may have this expertise, but it's something that you may want to consider. In terms of extended pelvic lymph node dissections, again, you may have to cater it to your local demographics, but the accepted validated approach is using the Brigandi's nomogram with a higher than 5% risk of lymph node invasion are the groups of patients that you would offer an extended lymph node dissection. And salvage radiotherapy is what we would recommend, and this is based on the Radicals trial. So the next few things are not as much detail, but it's just to emphasize on a couple of points. We've again got a very fit man. He's had some voiding low urinary tract symptoms. He's otherwise got a performance status of 0. He's got an IPSS score of 17. His DRE was benign. So we proceeded, his PSA was slightly high. So we proceeded with an MRI scan. Amit, would you like to comment on the MRI scan?
Yep, so there is low T2 signal throughout the peripheral zone, firstly. If you look at the diffusion sequences, there is diffusely low signal on the ADC map, top right, and bottom left is probably a higher B-value sequence, and you can see that there is some diffusely increased signal there. Now, I would say it's in the indeterminate range. The reason being is that, firstly, there isn't a target lesion. There isn't a conspicuous lesion, there's diffuse background change, and the enhancement isn't really helping there. So I would say this is a PIRADS 3, and to take into account the...
Okay, you are right. Again, complete inter-observer agreement between Dr. Patel and our local radiologist. So if I can go to Rajan, if you get this result, will you offer this patient a biopsy or no? He's got a PSA density of 0.16.
Yeah, so again, he's a young patient. His PSA is above his age-specific range. Although he's got a PIRAD 3 lesion, his PSA density is above the 0.15 threshold. So I would offer this patient a biopsy. Again, in our approach would be a transperineal biopsy, but looking at the location of this lesion, this is potentially something that could be obtained via a truss approach for people who haven't got facilities for the transperineal approach.
Would you consider monitoring this patient if he had a PSA density of less than 0.15 with no other risk factors of prostate cancer?
Yeah, it is an option. And again, it's something to discuss with the patient, and it would depend on what his views are. I think if he's happy to be monitored, then we could do that. But we've got to factor in that he is a young patient, and clearly where the risk and benefit lie, most patients would probably have a biopsy to be sure. But if he wants to be monitored, we'll be happy with that.
Okay. So he did undergo a biopsy. He had a grade group 3 prostate cancer, 1 out of 21 cores, and the single core that was involved had 7% of grade group 1 prostate cancer, which is Gleason 3+3. Oh, I shouldn't have shown you that, but Vish, what would you offer this patient?
Yeah, I mean, I would like to get some more information about his lower tract symptoms, whether the prostate size and any family history and Afro-Caribbean or anything, all the other parameters. And if there are no risk factors, and as this is clearly fits into the active surveillance criteria, so my first preference would be to discuss about active surveillance for him.
Okay, so to all our viewers, we did offer this patient active surveillance because you can see that this is a very small volume of grade group 1 prostate cancer. We also think that he's probably been classified appropriately because he's had an MRI scan, he's had a systematic and a targeted biopsy. So our hope is that this is truly a low-risk prostate cancer and the risk of progression is low. Now, what would we do with this patient? We check his PSA 3 monthly. In 9 months' time, we see him in clinic again. In a year's time, we repeat an MRI scan. And we may or may not offer him a biopsy, depending on the role of his MRI scan. What would be the indications for treatment? If this patient, it's patient choice. If there's PSA, radiological, or histological progression. By that, what we mean is if his PSA is sequentially rising, if his MRI scan shows progression in terms of from going to a T2 to a T3 disease, or more obvious lesions which go from PIRARS 3 to 4 or 5, or as histology goes from grade group 1 to grade group 2. Now, how we define radiological progression is a subject of debate. We've got a paper that's under review in European Urology on this subject, and it touches on some of the vagaries of this. I won't go into the details of that, but it's something to consider. Gagan, in India, would you practice this any differently?
Not really. I think in this fact, I completely agree with the points that Vish has made in this particular situation. The only thing I wanted to ask is this IPSS of 17 that you have said, it's without any treatment, or would the patient be already on alpha blockers at that time? Because if the patient is already
on
alpha
treatment, yeah.
Right. So one of the factors to consider over a period of time after you've counseled him would be his response to alpha blockers. And another thing that I actually want to ask you, because this is a matter of some debates somewhat, is that if you have decided to continue him on active surveillance, would you be adding dutasteride or finasteride in this situation?
I personally don't, for a couple of reasons, and part of it is the reduced trial, and in the past that there is some concern with these patients getting high-risk prostate cancer in the future, although that's perhaps not as conclusive. Secondly, I find it a bit difficult to monitor their PSA. So my preference is to avoid any 5-alpha reductase inhibitors. Would you do it any differently?
I think there are a lot of other factors to be considered. Like, we know that repeated biopsies and then having radical surgery are going to lead them with a lot of higher chance of incontinence and erection problems. At this point, my still preference is for active surveillance. Also, we need to say that if there is say in a 6 month or a year time, if there is a great progression and possibly T3 disease, he may not be able to have a nerve sparing surgery. So I think those also which are not discussed in length for these patients, those have to be also discussed in detail before you offer or change any treatment. But whatever the factors, my first preference would be for surveillance for this patient.
Bhavan, if I may add, I think one of the issues about this 5-alpha reductase inhibitors is that you are more likely to be able to keep this patient on active surveillance. And because of two reasons. One is that the patient is not going to panic for a slight increase of PSA because he's not going to get a slight increase of PSA. PSA, when it starts rising, it really means that something's happening, not just a kind of a fluctuation that you normally see, number one. And number two, these patients, especially with largest prostates, are likely to have a better control of symptoms over the long term. So the patient choice and PSA progression part will probably be taken care of better. And the point that you made about the PSA progression, can be, of course, corrected if the panel feels that I'm wrong. But I think that even if you have a PSA progression, you probably have to demonstrate progression in terms of the histological changes in the biopsy rather than directly taking the patient up for surgery. I think most of the times when we say PSA progression, it's actually patient's choice and patient becoming anxious about the fact that the PSA is rising.
True, but I think when we talk about PSA progression, we can have fluctuant PSAs, which is slightly different, but sequential rises of PSA is something that we should consider in terms of offering active treatment. I do accept that PSA is perhaps the least indicator of true disease progression, but it is something that we've got to factor in. It's not an absolute indication, but I do think we should factor it in. Okay, I think I'll go on to the next case. Now, this is slightly deviant from today's topic, but it's more a question of how we practice and if every patient really needs to be biopsied. So we've got an 81-year-old man. He's presented with back pain and he's not a very fit man. He's got a performance status of 2/3. He's got multiple comorbidities and he's on warfarin amongst various other medications. His DRE was suggestive of a malignant feeling prostate and he had no signs of cord compression. He had a PSA of 2000. Vish, in this situation, what would your approach be?
As his PSA is so high, he is likely to have a metastatic disease. So I think we need to get some form of cross-sectional imaging to find out about whether is there a metastatic disease. Yeah. So the bone scan clearly shows it's a super scan showing extensive metastatic disease. So in this scenario, I think our standard management plan would be to offer him hormone manipulation.
Anyone in the panel would offer him a biopsy?
No, but I think it's, the only issue is the medico-legal issue. Though everybody knows that this is obviously metastatic prostate cancer, I'm really a little bit concerned. So maybe maybe not like a 12-core biopsy, maybe like an FNAC of the prostate if something like that exists, or maybe as a 1-core or 2-core biopsy just to make sure that you've documented everything. Maybe I wouldn't like to biopsy if I can help it. Maybe do a PSMA PET, and if somebody finds a lymph node in the groin, just take an FNAC from there to prove it with some PSA staining. The only issue is medico-legal, and I don't know what's really happening in the scenario as far as your own, practice.
So Gagan, I'll give you a little bit of a perspective on this. We've got actually guidelines, both the NICE guidelines and EAU, and I suspect the AU as well. And they actually say we must try and avoid biopsies in this situation. Particularly in older, unfit men, we would be, I think, medico-legally more liable if we were to biopsy these patients and they have a complication from it. So our practice, even in relatively younger patients, it would be, if the evidence is compelling, to proceed with treatment. One, in younger patients, which sometimes we argue if we've got to recruit them onto trials, we would sometimes require histological confirmation. But if that isn't the case, our preference is to avoid a biopsy. Certainly in older patients, unfit patients, our recommendation is to avoid a biopsy. What are your feelings, Rob, on this?
Yeah, no, I'd agree. I think in this gentleman, I certainly wouldn't advocate a biopsy. I agree with you in a younger population, I'd be quite keen to get tissue. So, for example, trials such as Stampede require histological evidence. And I guess as we look to the future, as more treatments for advanced prostate cancer become molecular driven, things like tissue for testing for BRCA status and other things might be relevant. So I think in this situation, absolutely no biopsy, but I agree with the general principle that getting tissue for these men at an early stage in a younger, fitter patient who's going to be suitable for aggressive management is a positive thing to do.
I presume USICON is coming up with some guidelines or regional guidelines like BAUS or EAU or something, so they might work on that. And
yeah, I mean, that is true, because I think these kind of guidelines are lacking for where we work. But at the same time, you know, if it's the norm and it's published by the AUA and the EAU, I think for sure we can also quote that. And I'm better informed as a result of this webinar. Thanks, Bhavan.
Bhavan, can I come in there and add a comment?
Yes, please do, Rajan.
I think we have to strongly think about the consequences of any test that we request, and that just doesn't come with a biopsy or any test in medicine. I think you have to think about what you're going to do with the result of the test. If the test is unlikely to change your clinical management and you can manage the patient based on the information you've already got, it's not worthwhile proceeding with that test. So in this particular case, we've already got a malignant prostate on DRE. We've got an elevated PSA in the thousands. We've got a positive Gone scan. This patient has got metastatic prostate cancer. His treatment's going to be androgen deprivation therapy. The biopsy is not going to change that approach.
Thank you very much. So I think that concludes our MDT. I hope we've managed to cover most clinical scenarios. I do want to say that we've got 3 winners in our MCQ, 3 people who've performed really well. So the guy who performed top was Ryan Joseph. Well done to you. And Chitranjan Shah and Raju Ranjan from Kerala performed very well as well. They got the 2nd and the 3rd place respectively. So excellent. So thank you very much, guys. I think this was an excellent meeting. I think we should have more of these meetings. I think we've got perspectives from all over the world and they may vary slightly and we learn a lot from each other. So thank you very much.